Finally, the idea of this session in the morning was to go over the chronic coronary syndrome, because this is something very important, and thanks to our guests, we get in details coming through Anoka. And now the purpose of this session is to have some cases, to review some cases and to discuss upon them on the treatment and what should be done in different scenarios. So we're beginning with the first case. This is a case from National Heart Hospital. Dr. Vodimirov.
Hello everybody, thank you for the opportunity to present a case for our center. It is almost everyday case that is looking to be easy and so on, but unfortunately you will see that it's not so easy to deal with the ordinary cases. It is a 75-year-old male that is very symptomatic with stable angina. He has a history of hypertension, dyslipidemia, disabling stroke, heart failure. He was operated twice, once for nephrectomy and once for carcinoma of the colon. He drank a lot and has a liver cirrhosis with thrombocytopenia, and in the history he has an anemia. The ECG was almost normal. Echo shows left ventricular hypertrophy 11/11, ejection fraction 44 with inferobasal akinesia, dilated both atriums, mild mitral and aortic stenosis, and mitral regurgitation, second degree, with pulmonary hypertension with systolic pressure around 50. The laboratory was, you can see, eye-bodied. The thrombocytes are very low, almost normal hemoglobin, normal GFR, and very high levels of NT-proBNP. This is the angio of the right coronary artery. As you can see, it's diffusely diseased with a lot of calcium, significant stenosis in the mid, and chronic occlusion in the distal part of the artery. And this is the left system. Also a lot of calcium from the left main to the LAD, with a critical osteostenosis of the LAD, significant stenosis in the proximal to mid segment, and very, very eccentric lesion in the circ, which originates in the osteum. Here you can see also the other projection, and one very, very eccentric lesion that is just close to this, almost a loop in the artery in the circ. And we perform also left ventriculography. From here you can see that the zone of the right artery is almost gone. So it comes the first decision what to do with that patient. It's a very, very frail patient with a lot of comorbidities, very symptomatic, very high scores for both operation, both PCI, and also very big problem after that with these low levels of thrombocyte for both surgery and long-term dual antiplatelet therapy. So, as usual, we organized the heart team. The surgeon said, guys, please, it's not our case. Do whatever you can. Optimal medical therapy, I think it's not an option for that patient. And here was our approach. We first was not sure about the significance of the circumflex artery. That's why we plan to take a side branch wire that is wire-based FFR and FFR, just to see if it is functionally significant or not. We use a 7 French ABU catheter. Why 7 French? Because there are several steps that can be a disaster. The calcium, the tortuosity, left main LAD circ that we have to manage with, and also if we decided to use some kind of debulking system like rota ablation or orbital arectomy in the both vessels, we can divide it, the wire from the one to the other branch with a guide extension catheter. We decided to use orbital arectomy in that case because it is a machine that can cross these lesions, do the retrograde runs, which give less dissection. We are a very big fans of DCBs, and we have some cases with DCBs and rota and orbital arectomy, and that's why we were thinking to have less dissection in order not to give so much stents in that patient. This is a 6 French compatible system that can go through a 6 French guide extension catheter, and it's very useful in the tortuous vessels. The first step is to make the RFR and the pullback. You can see the drop. The RFR is 0.74, which is functionally significant lesion in the circumflex, and the drop is just at the place where I put the circle. It's not in the ostial part, it's in the distal part of the circ. And if you can see, if we manage with that stenosis, which is quietly small, not so long, we can have a very nice RFR of 0.80, 90. We will see in the end how it is after the procedure. So the first step is to put the Viper wire. This is the wire that we use for orbital arectomy. It is a very friendly wire, I can say. More easy to manipulate compared to the rota wire. We managed to cross this critical osteal lesion without any problem, and we don't use a microcatheter in this part. Try to put the IVUS through it, but unfortunately our IVUS is a little bit old, and it's a bulky device, and we cannot go with a Volcano IVUS in the LAD. So we started the procedure. As I told you, we use the retrograde way to manipulate the Diamond-Black in the coronary arteries, start from the mid segment to the proximal segment and the osteal one with a very slow pullback of the machine. Backwards, we do several runs. The machine is very easy to operate. It gives you every, I think, 30 seconds it gives you a signal, so you cannot do very long runs like the rota can do. This is for safety reason for the patient. Also, this patient has a occluded right, and we want to have a nice flow, so we were very careful with the machine. After that, as I told you, our strategy first was to put only DCBs, but after predilatation with the scoring balloon, I don't have the image, only we just give some very little amount of contrast, but you can see just before the implantation of the stent, there is a very big dissection after the scoring balloon in the proximal part of the LAD. So we have to put a stent. The stent was 3023 based on the IVUS that we did just after the rotablation and after the dilatation with the scoring balloon. And then we move to the next artery. This was the circ. We use guide extension to separate the wires, LAD to the circ. Again, we managed to put the orbital arectomy device distal to the stenosis and give some retrograde, and in this case some antegrade runs. You can see how tortuous the segment was, and it was followed by predilatation with a non-compliant balloon, 2.515, and then only DCB. in that part of the circ where the stenosis was. And then we moved to the left main, provisional stenting with a 3.526 platform that can give us the opportunity to post-dilate with bigger balloons. You can see it is almost well expanded stent even before the IVUS in the left main and in some parts of the LAD. Then we do pot side and repot with balloons 2.512 in the circ and 5012 in the left main. And this was the run of the IVUS with some measurements that I made. You can see the left main is area is more than 13, 13.7. The LAD proximal to mid segment is about 6.9, and there is only one place where the elliptical part is the area is 0.3, which is, you can argue with me, but I think acceptable result in that case. This was the final angio and the final result for that patient with LFR 0.91 in the circ. And I would ask all of the audience, how would you treat your next calcified left or right coronary artery? Please don't do it only with the angio-guided approach. Use the compass in the face of physiology and imaging combined together. You can use rotablation, you can use orbital alectomy. It's very useful and friendly device. And always think about the sign branch where you can use a buddy wire, which could be a physiological assessment wire. Always use the IVUS for searching for stent position, stent expansion, and optimize wherever you can, because every millimeter you gain, it's decreasing of the MACE of the patient. Thank you.
Thanks. Very nice case, interesting. With revascularization comments.
Congratulations, excellent results, very nice case. I have two points maybe for you to discuss. I'm very curious about your usual, except this very case, your usual approach, because this is, we could say this is a stitch-like patient profile, and but we struggle with our surgeons to have them accepted for surgery. I don't know if you share the same experience. And the other point is how often you consider in similar cases to use mechanically circulatory support. We don't have the definitive data. The trial is still under still ongoing, but there's also always a trade-off between benefit and risks, so access risk and so on. So what's your usual approach?
In our center, we have only intra-aortic balloon pump, and I think that this is definitely not the case for that, because the cirrhosis, low levels of thrombocyte, it will kill the patient. But usually when we argue always with the surgeons, and almost I'm the guy that argue most with them, even in acute cases, to take them, because it's a 100% surgery case. You have an occlusion of the right, there is an aneurysm they can fix, but because of the comorbidities and the disabling stroke, they said no way. So usually we do this. I think if the patient don't has the comorbidities, a balloon pump should be put from the left or the right leg, and then start the procedure on top of it, because there's no aortic regurg. He has a heart failure, and this will help us a lot if something happens with the blood flow during the procedure.
Um, Not exactly in the stitch range because the stitch patients, they were around 60. And this is 70 plus. And on the other hand, to benefit from the stitch study, this patient has to wait 10 years, which is not probably the right thing for him. I fully agree with that's an excellent procedure, but for me, this patient is something what we've discussed yesterday. Probably when we're using different devices to treat calcium, to calcium ablation, we have to use, especially in big vessel, a different, complementary approach, because you have a very good result. Yes, 5.3 minimal stent theory is something that should be considered, because at least probably a stepwise approach. I will bring this patient back and probably put a shockwave there, because on the IVUS, I have the feeling that there was a calcium nodule there.
Yeah,
And
there was a
still,
lot of calcium.
if you do not, this is what we usually have with a big vessel and severe calcification. We have several cases in which you go with the rotablation. We have the rotablation, and after that, trying to expand, to crush additionally the calcium, you cannot do it. And that's why in these cases, we go with a second approach. This is the IVL. And probably what I was going to do is
But
try.
on the next session, you're going to do it?
Yes. On the next session, I think you should follow up this patient, because the woman is quite good. Still not reaching the 5.5, let's say the golden criteria that we want, but it can be followed up, and if some issues in restenosis, probably you should go and do IVL and optimize the result, because let's say it is a phone off-label using the IVL balloon in freshly implanted stents. Dobri?
Congratulations for the case. Следващия път, след като си представиш кейса в началото, спираш за дискусия и след това продължаваш да представиш какво си направил до край.
Попитах панела, казаха да не спирам. Ще ми спрат, съжалявам.
Ти си го накарал. Добре. Жоро, аз имах един въпрос. Какво ще стане, ако този пациент с тромбоцитопения изкърви и трябва да му се спре двойната антиагрегантна терапия? И защо ехографската фракция е 43, ангиографската е над 60? Ама това са подробности от пейзажа. Ще продължим нататък. Да. Excuse me, but I have some notions internal for Bulgarian audience only. Okay, so the next presenter will be from St. Anna, and okay.
Thank you for the opportunity to present our case. It's a simple one, but still we can discuss a few things about this patient. I'm from St. Anna Sofia Hospital in Bulgaria. Okay. It's a very young gentleman, 33 years old, with no prior history of cardiac disease. Nonetheless, he presented with inferior STEMI to our clinic, and he was sent to an emergent angio, which revealed the following. As you can clearly see, the LAD has no stenosis, but the circumflex is the culprit lesion, and you can see that there's also a retrograde filling of the vessel. What you can also see is that this patient has a occluded RCA with collaterals through the septum, and this is the RCA. what we did was fix the left circumflex, which is actually a very large obtuse marginal, second obtuse marginal branch with 2 stents. And this is the final result. Now, I'll stop for a little bit and ask questions to the audience and to the panel, and I wish for everyone to think about it and raise your hand if you do the following. Should we revascularize fully? Should we open this occluded RCA in this very young patient, 33 years old? Now, this is the control echo, which is around 2 weeks after the STEMI, which shows no motion abnormality. And let me remind you that when he came, he had inferior hypokinesis. Now he's symptom-free. Okay? Let me ask the panel, would you open this RCA?
Just a first question. Symptom-free means that he's sitting at home
No, he's
in front of the TV and he has no symptoms, or he's jogging 3 kilometers every day?
He's a physical worker,
Okay.
33 years old, and he does not have angina or dyspnea.
Okay.
He's very active.
Huh? Like 5 years ago? Okay.
No, is the same before and after the STEMI. So yeah, would the panel open this RCA, and maybe we can ask the audience to raise their hand. Who would open this RCA? Okay, very few people. I think 5, 6. Okay, would you need further tests like MRI, PET scan? Would you test for viability first and then do the recanalization? Yeah, probably. Okay.
Just a minute. On echo, there is no
No motion abnormality.
no notion, and there is no myocardial thinning.
My first question is,
No.
what are
No.
the risk factors?
No risk factors.
I mean,
Is there drug
DCPD.
abuse, narkomania,
No,
нещо?
only family history, but family history of premature CAD, but no risk factors.
In the first event, did you consider to perform intracoronary imaging, given that there is a very young patient with no risk factors?
No, we did
And
not.
if you could see again the image,
Yes.
if it is a male, if it is a female, I'm sorry, I consider a spontaneous coronary artery dissection because the aspect of the lesion I put in differential diagnosis. It's more frequent in female, it's true.
Yes.
But regarding the patient, we don't have cardiovascular risk factors. Did you consider to perform coronary imaging?
No.
Okay.
Yeah, it could be spontaneous, but I think that most probably it's atherosclerotic.
Okay.
And you can see the CTO.
Yeah.
So
so
we discussed everything with our team, and I wish to, probably everyone is familiar with this, but still, this is the 10-year follow-up of the EXPLORE trial, which shows that there's no significant reduction in mortality at 10 years after CTO intervention. Actually, there's a little bit of mortality going up in the PCI arm, but still we are not sure why is this so or anything. But 10-year follow-up, to me, this is the only trial that has so many patients that are after STEMI and 10 years followed up. So we discussed everything with this patient, and he refused further testing and PCI. We actually wanted to open this RCA, but he refused to do any intervention. 2 years go by, and he was again symptomless. But in the last month, he came back with a very, very, very maybe grade 4 stable coronary disease, He had a very low threshold for angina. And what we did was a control echo, which again revealed borderline ejection fraction with inferior hypokinesis. We tested the troponin, which was negative, and we did a control angio, which revealed the following. He now has a very tight critical stenosis of the LAD, which appears to be in the middle of the LAD, and actually you can see that there's a retrograde filling of the diagonal branch, first diagonal branch, which actually is occluded just there at the stenosis. You can also see in the caudal view that there's also a almost occluded circumflex, which has TIMI1 flow, and you can still see the right RCA, which is filling through the septal collaterals, but it's not filling all the way up like it used to be. Now in this view, you can see also the tight lesion of the LAD. And now the right coronary artery has some antegrade flow, which was missing the last time. Maybe it's bridging collaterals, maybe because of the tight lesion of the LAD, and the septal collaterals could not support so much blood flow to the RCA. Now there's a little bit of antegrade flow, but still it's occluded. Now I want to ask you again, would you do revascularization or no in this patient? Who would do only medical therapy?
If you allow me, sorry
Yes,
for
yes.
interruption. Because of the brisk flow from the collaterals from LAD to the right coronary, sometimes we can see on the previous, before this aggravation of the disease, sometimes practically antegrade flow is not visible through the microchannels. And when you have now critical stenosis on the LAD, which compromises the collateral filling of the right coronary, now you can see the microchannels who are filling antegradely, and this is one of the explanation that from time to time, suddenly, but it is not sudden, appears some flow, and during the disease course, the collaterals, also the autocollaterals and bridging collaterals develop inside the vessel. So it is not so surprising for appearance of this antegrade flow.
This is not antegrade flow. This is a CTO with collaterals from the ipsilateral.
Yes, it's
let's,
probably
put the
bridging
things,
collaterals.
We have documented CTO before 2 years. so
Okay,
it
this is
really
a
the
question of terminology, but anyway, the feeling is from right to right, okay?
Okay, and to the question.
Do you check internal mammary artery on that side? Because you discuss the method of treatment in these patients.
Yes, exactly. No, we did not check. Okay, who would
I'm still curious to see what is his cholesterol, LDL, his profile.
Before the STEMI, it was LDL was 3.4, and after 3.4 millimole.
And now?
And
do we have a treatment which is adequate?
I'm not sure if he did take his statin, but it was below 2.5 LDL. So the second time it was around 2.3, something like this.
I mean, he is not. The risk factors.
He was not in
are
target.
not
Yes,
addressed,
yes, exactly.
There is no control on the risk factors,
Yes.
which is extremely important, and I'm repeating many times
Yes.
that this is what treats patient, not stents, not bypasses. The
No,
medicine is what treats patients.
Nevertheless, what we are choosing, this is the first thing that we should do, and probably see some other risk factors. I mean, lipoproteinase, small one, because this is unusual, aggressive coronary artery disease.
Exactly, yeah. But still, who would do only medical therapy? Raise your hands, please. Only medical therapy. Nobody, okay. And we have the guideline to support
But
it.
the question is why?
And then,
in the patient who don't take his medications. It's good. It's a good choice to decide to deliver the patient on medical therapy who is not taking his medical therapy.
I'm not sure if he was taking, the LDL was lower, but I'm not sure if he was taking the medication. Okay, and now, if everybody agrees that we should do revascularization, what type of, should we do CABG or PCI? Now the syntax score is around 25. I did the test, the score around 5 times, and this is probably the most true answer, around 25. So we see 36 to 26% MACE, CABG versus PCI. Now, it's intermediate anatomic complexity, and the guidelines say that we still, in low and intermediate anatomic complexity, can do PCI, but maybe in this young patient we should prefer to do the CABG. Okay, now I'll stop again and ask the panel and everybody, what would you do in this situation? And this is the syntax 2 score.
In this case, my first strategy is to discuss with surgeon, and
Okay.
I will prefer the CABG in this patient because we have one failure vessel treated with stents, so I prefer CABG in the first intention.
Okay.
CABG or arterial grafts?
Arterial grafts.
Should it be full or partial revascularization? How many arterial grafts? 2, 3?
Complete.
Depends on the surgeon.
Complete.
Yes, okay. Okay. And we did discuss it with our surgeons, and we sent him to the surgery room, and he received left internal mammary and right internal mammary, and they left out the RCA, the CTO. So maybe we should open it now. What do you think?
That's a good option for the patient. That's what I was going to discuss. If full arterial revascularization is feasible in the center, it should be done. If not, at this point, because he has an acute coronary syndrome before that, probably it's time to evaluate full ischemia and viability, because if you have a scar there, probably it's not worth opening. Still, this is what should be done. But in my view, this CTO, let's say, is not that complex. Probably it is 0 to 1 JCTO score, and it is worth opening and to have his to have complete revascularization, unless there is a definite scar in this region.
So we should test him and then decide.
Yes.
Yeah?
Something, I mean, stress echocardiography, scintigraphy. These are the, I mean, these are the tests that we can have in Bulgaria for a moment to detect ischemia and viability. MRI, I haven't had to do a stress MRI in Bulgaria. I'm not sure.
Okay.
Ще научиш, да.
This is
Just one question. How the surgeons explain why they do not bypass the right coronary?
It was a difficult talk, and we couldn't understand why they didn't do it, but still.
That was surgical decision.
No,
Yes, exactly.
Usually they
Exactly.
don't have
During
plan.
operation.
No, they don't.
But good job, because the Rima graft is to
Yes.
CX. This is very skilled surgeon.
Yes, exactly. To put Rima on the circumflex, it means really skilled operator, and to leave this type of right coronary unbypassed is very surprising for me.
I think the right mammary was end-to-end graft.
And
Yes.
what about RCA? Venous graft.
No, it's two arterial, but the RIMA is end-to-end graft.
Uh-huh.
Probably the surgeon is passionate about CT or PCI.
Yeah, probably. Okay, thank you everyone.
And what happened next? You left the right? You?
I want to stress another point because in my mind this case is interesting because the patient is young and I would like what's your opinion, is this patient too young for surgery? Because this is another point, if you operate so young patient in 20 years, post-CABG bypass patient, it's going to be a really tough job for us and it's kind of discussion. Is that young patient for PCI and probably in few years for surgery, or this is not a point for discussion? If it's young, three-vessel disease, go.
So Dr. Vladimirov said that he's for DCB treatment. Dr. Dimitrov?
Thank you for the case. I just have two comments. First, did you think to test this young guy for some kind of thrombophilia? Because he is young, he has acute MI, another CTO, so maybe you could have tested him.
Yes.
If he has diabetes or if is he a smoker, if it's without typical risk factors, sometimes very young patients, below 40, they have some kind of thrombophilic condition sometimes. So it's worth testing. It's worth testing. And I would like to ask the experts, the panelists, because I think that a young patient with a right coronary CTO, he may not have complaints at first, but if you leave him at 30 years with a CTO of the right, and he has an acute MI of the LAD, which almost happened, he would have died instantly. So in a young patient, I think it's worth continuing as you wanted to do. Maybe there's an indication there to do CT or PCI of a young guy who has a huge coronary, right coronary, because if should something happen in the future in his left system, it's going to be catastrophic.
I think you're right. He had no diabetes, and I think that we taught him to test for everything, but he did not do it. Yeah, also LP Little so on. Yeah, but he didn't do it.
May I just add a very quick one? Of course, the testing here is, I think we all agree that we should test for thrombophilic issues, but we also have to remember that this is only positive in a few minority of cases. So we have European level data about this. So most of these very young patients actually have traditional risk factors. And so this is very important to stress again the secondary prevention in this case, more than usual, because these are younger and have a projected risk in their lifetime which is higher. And then the other point is, of course, the discussion with the surgeons, because I think this is a very good example of a patient who should go to heart team before any treatment, because we ended up with the patients with incomplete revascularization. So heart team should not be just there to validate for TAVI indications, but also for similar cases, because probably should you have known this, you would have changed your attitude to PCI, should you?
Okay, just to say, because Dr. Stoyanov asked about the young patient going to surgery. For me, patient who is not taking medications, this is an absolute indication for surgery.
And then
Just because PCI requires strict adoption of treatment. In patient who is not keen to take his medicines, It's better to send the patient to surgery because surgical treatment is much more resistant to known medications, at least antithrombotic medications.
But because we are shifting a little bit from this is our duty, it is our responsibility to convince the patient to take the medications.
You
This is
can
one
convince
side,
somebody
and,
who has
we have
something
to work
between the
quite a
ears.
lot on this. And yesterday, sorry, there was the lecture of Dr. Wupit that we have from Serbia, very kindly organized for us. This is something that we should go and in such patient, especially that young guy, find a way to motivate and increase his compliance. That's as a remark. Otherwise, we should find the optimal way of revascularization. And what I'm going to say, yes, probably, interventional treatment is better, in my view. We don't have data. Is better for young patients because surgery early in early ages, in a way closes the way for second operation. And we exhausted one very important revascularization strategy. And if possible with interventionally, with stents or balloon, this is another topic, unresolved yet, we should keep this. On the other hand, if we have to put stents distally and, let's say, challenge future bypass grafting, that's something that we should consider too.
Dr. Farandju? And that will be the last comment.
For the cardiac surgeons here, maybe if there are any cardiac surgeons in the room, they might explain, but is it possible that the reason they didn't revascularize the RCA was that they did it op-cap? I'm not familiar, but maybe someone can explain.
Okay. It doesn't matter. It should be done. Even if you go there, put the patient, in my view, and you do a sternotomy, this patient should go out fully revascularized, even with the saphenous vein graft. That's what I think.
I think that the surgeons rely strongly on their interventional colleagues who will finish the job. Okay, thank you so much.
So, next case from Medical Dr. Mireva.
Hello again. Now let's finish with our case that it has some similarities with the previous one, but let's see. So our patient is a 69-year-old male. He presented with precordial oppression, with dyspnea on mild physical exertion. He was hemodynamically stable and he was obese. As a medical history, he had known arterial hypertension, known coronary artery disease with a history of inferior STEMI with PCI, one stent in the RCA 3 years ago. He has known dyslipidemia and he's a long-standing smoker. This is a therapy that he was receiving when he came to us. On the ECG, we saw that he had a left bundle branch block. From laboratory findings, there was nothing specific, not very well controlled lipid profile, and a little bit higher glucose. When we did the echocardiography, we see dilated left atrium, dilated left ventricle with lower ejection fraction, and some kinetic disturbances on the inferior wall and inferior septum, which were correlating with the history of inferior STEMI. We decided to perform MRI in this patient in order to evaluate first the vitality of this inferior wall, and also we were doing a stress protocol MRI to see if there is some ischemia behind these symptoms of angina and dyspnea, or if it's pure heart failure. So this is the cardiac magnetic resonance. As you can see here, very nice, the inferior wall is very thin, completely akinetic. Otherwise, Left ventricle seems fine, but the inferior wall is probably completely fibrotic. We confirm this with the late gadolinium enhancement on the CMR. You see there's complete transmural fibrosis on the inferior wall and inferior septum. The other walls of the left ventricle seems okay. And we did our stress protocol with dipyridamole. What we saw from the stress protocol in rest and in stress after the dipyridamole infusion, we see that there is no perfusion in the inferior wall. So we have confirmed that there is no vitality in the inferior wall. However, we see some disturbances in perfusion after the dipyridamole in stress on the anterior wall. So probably there is some other ischemia on the anterior wall. So this was our indication for invasive coronary angiography. What we saw, there is occlusion in the stent in the posterior lateral branch. From the left system, we see some mild stenosis on the LAD, proximal LAD, maybe 40%. So what our colleagues in the cath lab decided to do was functional evaluation in the LAD. We see FFR 0.9, so non-significant epicardial lesion. However, you see the microvascular function. CFR is 2.4, a little bit below the reference of 2.5. However, IMR is very high, 69, so very high microvascular resistance. We decided to do also PPG with pullback inside the LAD, and we see that the PPG 0.45, which speaks for diffuse disease in the LAD, no focal gradient. So now my question is, what do you think, how we should treat this patient?
By the way, this patient was referred to me from our cardiac surgeons. This patient was referred for CABG. But surgeons, because we saw not this is the angiography from our lab, but surgeon saw the film and called me just to think again about
this patient is
what to do.
for CRT. This patient
CRT is clear.
has indication for CRT.
35.
On the edge. Optical medical therapy, probably CRT. Very nice case. The FFR was
0.9.
84.
0.9.
0.9. So it's, in my view, an example of combination of obstructive and non-obstructive coronary artery disease. So the focus should be something else, and there is left ventricle dysfunction. Let's say serious left ventricle dysfunction, and this is something that we very often see with, in this patient, we very often see non-obstructive coronary artery disease, and this is the type usually they proceed. He has medical treatment optimizing in two directions. I mean, for the left ventricle dysfunction, as we mentioned, probably CRT, and a treatment for the non-obstructive coronary artery disease. And sometimes this treatment overlaps, so it is easy to cover all the other things. Okay, that's what I propose.
Yeah, this is also our direction of thinking. We decided it's a patient with heart failure, with reduced ejection fraction, with occlusion of RCA but no vitality in the inferior wall, and with evidence of coronary microvascular dysfunction. So we optimize the therapy regarding the heart failure with reduced ejection fraction and the coronary microvascular dysfunction, and we referred him for implantation of cardiac resynchronization therapy. And that's it.
And probably I have the feeling that this patient will increase his function because why? Because the CFR is only 2.4. It is on the boundary, and the most important thing in let's say as a prognostic factor is the CFR, not that much the EMR. So this is something that probably will be in a good direction for this. Excellent case. Comments from? So, thanks to the participants, thanks to the panel, really.